Dear Professor Rainer Höhn, dear colleagues, dear faculty members, dear participants of the Global Psychiatric Association online conference, first of all, I would like to express my sincere gratitude to Professor Rainer Höhn for the invitation to participate in this very important professional event. And it's my pleasure and honor to contribute to such event for the second time. Last time I was talking about linguistic issues in schizophrenia spectrum disorders, and today I'm going to talk about language of depression. Let me introduce myself once again. My name is Daria Smirnova, and currently I act as a director of the International Center for Education and Research in Neuropsychiatry. And we have an interdisciplinary and still international team. And we hope to collaborate on psycholinguistic research with every one of you in the future. One of our plans are also to publish a special issue of the Global Psychiatry Archives devoted to the linguistic aspects of mental disorders. So the topic of my today's presentation is language of depression, how it's spoken, and why it's important to listen. I will address you to the 2 papers we haven't published. The first one is titled Language Patterns Discriminate Mild Depression from Normal Sadness and Euthymic State, which is published in the Frontiers in Psychiatry. And it describes the superficial level of speech, so-called lexical, grammar, and stylistic characteristics of speech of patients with the state of mild stress-related depression. And another paper, which is titled Language in Mild Depression, How It Is Spoken, What It's About, and Why It's Important to Listen, published in Psychiatry Danubina. And here you can see the details about the content and what patients with mild depression actually was speaking about being in the state of mild depression. Mild depression is a common mental state observed in almost 15% of the adult population, with only 23% receiving any treatment. Mild depression is mostly related to life stresses, so it's stress-related, and unlike moderate and severe major depressive disorder, it is poorly responsive to antidepressant medication, as Kessler says. Mild depression, as distinct from subthreshold minor depression or normal sadness, is a serious medical condition causing professional and personal disabilities and associated with unemployment in more than 16% of cases. The chronic course of mild depression symptoms within dysthymia brings an elevated suicidality risk compared with major depressive disorder, so this is a risk state for suicidality. Mild depression is often prodromal to major depressive disorder, and we should take it into account, really, as clinicians. Normal sadness is the absence of clinical depression, but it's also a frequent state which is observed in 29, almost 30% of the general population worldwide. Diagnosis of mild depression requires 4 symptoms according to ICD-10 criteria, 7 main symptoms based on DSM-5, and thresholds for scores ranging from 7 to 17 is widely accepted by clinicians, so cutoff scores from 8 to 16 as suggested by the recent severity classification of the Hamilton Depression Rating Scale, 21 points. Depression is heterogeneous and presents with highly variable clinical symptoms, so its diagnosis cannot be made merely by the number of symptoms, but should include their detailed analysis and causal relations, Goldberg and Kessing emphasize it. Diagnosis of mild depression was reported to be less stable compared with diagnosis of severe depression using ICD-10 criteria, and was characterized by a fair level of agreement. Kappa was only 0.25 between clinicians, compared with the moderate reliability in severe depression cases which are diagnosed easier by clinicians. Kappa is twice higher, which is reported in the papers published by Kessing and Maria May. The claimed high prevalence of mild depression is sometimes viewed with some sort of skepticism, given the questionable reliability of psychiatric diagnosis in general, and especially with respect to the differentiation of mild depression with a state of normal sadness. Horwitz and Wakefield and Maria May as well discuss this topic. Correct recognition of subthreshold forms of normal sadness is based upon the number, duration, and quality of presented symptoms. Despite the elaboration of criteria cited above, psychiatry still lacks objective clinical tests of symptoms comparable with those routinely used in other medical disciplines and somatic medicine. Affective, decreased mood, and cognitive, such as negative content of thought, sedation, components of mild depression, and normal sadness are mostly expressed through language, while most severe forms of depression are also recognized by a motor component, like slow bodily movements or motor retardation symptom. The search of objective indicators of mild depression versus normal sadness might help to increase the reliability of mild depression diagnoses. Andreasen and Vogel first show that language is a specific marker of depression, and currently active study groups have concluded that an analysis of natural language processing could afford the foundation for developing objective diagnostic tests based on dimensions of observer behavior, like language phenomena really is. While a clinical interview still remains the basic tool for diagnosing depression, linguistic research has demonstrated that systematic analysis of language content reliably classifies our patients into appropriate diagnostic groups. Computerized word counting techniques discriminate depression communities from other subgroups and also reveal strong online language predictors of depression and suicide. Aberrant written and spoken languages are frequently reported in depression. And here you can see the paper published in the Proceedings on Privacy-Enhancing Technologies, because I was told so much, where they show the linguistic indicators of mental health status on Twitter. And here you can see how they separate by the keywords presenting over the posts of Twitter content people with depression and healthy persons. So you can see that such words like don't, can't, ill, didn't, wait are associated with depressive state more often. Another interesting paper has been published by US researchers. It is a depression screening via Facebook posts, which could be used for prevention and early diagnosis of depression. They found language markers, predictors of depressive state, via analysis of the wordings and keywords posted in social media. So it can help us with early diagnosis and early intervention and early access to treatment for such people, represented vulnerable groups for developing depression. as you know, from 7 to up to 26% of people are diagnosed with depression in the United States, whereas only from 13 to 49, according to different studies, of this diagnosed population receives minimal adequate treatment. So there are gaps we still need to explore and fill with our actions and interventions. So what they really found that there are some emotional language markers and topics presented in people with depression. And these major topics, which were analyzed with such tool like linguistic inquiry, word counting procedure, are depressive mood, representing with such words like tears, cry, pain. Another topic is loneliness. For example, such words missing much, baby. Hostility, such as hate, even uncensored lexics. And as for lexical level, we also find first-person pronouns like I, me, my, mine, and stylistical issues like content repetition and ruminations of the same, mostly negative topic in the posts of people with depression. This big data analysis proved the linguistic predictors of the diagnosis of depression. And here the slide, you can see the topics and the key words related to this topic: depressed mood and feeling, loneliness, hostility, somatic complaints, and different medical reference, which is also an interesting point. Variations in Facebook posting patterns across validated patient health conditions was a very interesting prospective cohort study, and it showed surprising data that the increase of the number of Facebook posts is correlated with the depression in Facebook users. So people with depression may post more information when they feel worse, and it could be additional sign, diagnostic sign, and indicator of depression worsening. Linguistic predictors of suicides have been also revealed over Facebook content, and they are related to the negative content of the posts, to the low mood and words associated with the low mood presented by posts, again, somatic complaints and issues, and this high posting frequency, which we already mentioned. These are also linguistic predictors of suicides. It is also a very interesting study, a corpus-based study by US researchers, again, understanding depressive symptoms and psychosocial stressors. They develop an annotated corpus, depressive symptom and psychosocial stressors acquired depression, so-called the SAD corpus, consisting of 9,300 tweets randomly sampled from the Twitter application program and interface, using depression-related keywords such as depressed, gloomy, and grief. And what they show is fantastic. They could really discriminate. They can really find two corpora, the corpus with keywords related to sadness, normal sadness, and clinical psychiatric state of depression. So at this slide, you can see in detail the topics and related keywords which are associated with sadness, normal sadness or ordinary sadness, which is also a risky state to develop mild depression, and real clinical state of depression, which requires our interventions and treatment. Being a chronic affective disorder presenting either with mild depressive symptoms or with marked absence of pleasure in daily activities, dysthymia is characterized by increased speech flow in contrast to the slowed speech typical to major depressive disorder, Homestead written. The excessive use of first-person singular pronouns such as I correlated with depression in many but not all these studies. Objective, me, and possessive, such as my, first-person pronouns were more frequent in speech of a group with depression and predicted depression better than did subjective, such as I pronouns, Smirnova analyzed. Elevated usage of first-person pronouns was attributed to self-focused attention phenomena or self-preoccupation, which is often observed in stress-related neurotic states. Among various measures of depressive self-focusing style, rumination, repetitions of the same, usually negative information, has been mentioned in many of these studies. Other features of depression included elevated use of mental state words such as think, suggest, suppose, guess, words denoting causal relations such as because, Penny Breaker wrote about this, greater use of generalizing terms like everything, always, or negation, nothing, never, such as words which characterize polarized emotions, everything or nothing, always or never, and words referring to these ambivalent emotional states, published by Gode and Postenberger. The increased use of discrepancy words such as should, possibly reflect an enhanced aspiration for the future, has been discussed as a marker of improvement with therapy of depression. Together, these promising results denote that both the styles in which people use words and the content of what they say, as well as the language per se, represent equally meaningful information about their symptoms for us clinicians. Nonetheless, language phenomena are still not widely considered for psychiatric diagnosis of affective state by our doctors and psychologists. What we studied more than 200 people with mild depression. The protocol was approved by ethical committee of the university. Participants were of the 20 to 60 years old to decline some cognitive issues of dementia state. They were Russians, so speaking Russian as native language, completed secondary educations. There were absence of psychiatric comorbidities within the inclusion criteria, and the absence of any overt medical or neurological disorders or acute exacerbation of chronic somatic states. So here we see that the first group was mild depression patients with a mean age 42 and 76% of females, 46% single or divorced, and 53% college university degree. According to ICD-10, you can see the codes. So all these conditions were stress-related depressive states, and the stress factors have been revealed during clinical interview, mostly adjustment disorder, pre-depressive reaction, adjustment disorder, prolonged depressive reaction, and adjustment disorder, mixed anxiety and depressive reactions. So we saw also the symptoms of anxiety combined with depressive symptomatology in these persons. And the group of healthy control was subdivided into two subgroups of healthy person, normally healthy individuals, 42 of them. They were matched by age, 79% of females, almost the same. And the second subgroup was the individuals in a state of normal sadness, 35 persons. We call them as persons with the state of normal sadness. And by ICD-10 categories, Z56 to Z63, like problems related to employment and unemployment, housing, economic circumstances, social environment, primary support group, and other stress-related issues. So for the text analysis, there was a group of experts, psychiatrists, linguists, and clinical psychologists, and we studied from more than 200 narratives, written self-reports on the topic of the current state of life and future expectations by our participants. Only one rater, psychiatrist, was necessarily informed about the clinical state of the individuals, patients, or the healthy controls. The other two raters were blind regarding the group assignment, and both blind raters analyzed the entire sample of excerpts regarding linguistic variables. The instructions was given orally by research as follows, like, please write as much as you think is necessary and take as much time as you need to describe your current state of life and future expectations. And the methods were presented with clinical interview, with using Hamilton Depression Rating Scale to assess depression, psycholinguistic variables at the lexicosemantic level, like measuring metaphors and rhetorical figures, syntactic indicators like predominant sentence type, single clause and multi-clause, lexicogrammatical variables like using pronouns and their types, and semantic variables like using keywords and semantic categories analyzed via component analysis of speech. And here you can see the statistical data analysis we used, including mathematical modeling to measure the weight of the linguistic indicators in the affective state. So here you can see the linguistic indicators we studied for lexicosemantic variables were presented by categorical variables and their predominant type. For example, like language type could be evaluated as narration, which is description of facts, states. For example, I started having thoughts that I was causing irreparable psychological damage to my child and husband. Or reasoning, assessment, causal relation search. For example, I was asking myself, why do I have to go there? And I couldn't find an answer. And also there were quantitative variables like colloquialism, informal words and phrases like don't have enough spirit, or tautologies, word and phrases, repetitions, I was doing it again and again. Lexical and semantic repetitions such as I was crying and sobbing, and figurative language patterns like rhetorical figures within metaphors and similes, figurative comparison like I'm drowning into this grief, and similes like direct comparison, I was thin as a skeleton. And these quantitative variables were calculated as quotients, the number over a span of 10 sentences per text. Also, syntactic variables, we focused on categorical variables, for example, predominant sentence type, single clause. For example, I'm just a source of trouble for my family and friends, or multi-clause. I didn't think that such a darkness, cupola would descend upon me. Or single clause sentence example, impersonal, it only gets worse without personal pronouns. Or reduced, life is a swamp. Or complete, I just wanted to lie on the couch all the time. Or incomplete, wanted to not wake up. And complex multi-clause sentence examples like absence of causal relations between clauses contained within one sentence, complex sentences. For example, recently I have been thinking more and more often that nobody needs me, nobody cares about me. And compound sentences like presence of causal relations between the clauses contained within one sentence. I keep asking myself why I became like this. And the word order, it could be usual, typical, correct syntax rules. I became a throwaway from life, or unusual, atypical. A life of mine became difficult. Not my life became difficult, but a life of mine became difficult. And also quantitative variables, like unusual, atypical word order, rhetorical figures like ellipses, omission of words. He could do it, I could do. And inversions, unusual, atypical, inverted word order. Never have felt this way before, which also emphasized the emotional expression. And lexical grammar, lexical grammatical variables, we studied personal type pronouns, verb tenses types, continuous or perfect, continuous like was trying or perfect, have done, verb tenses, past, present, and future, and pronoun types like indefinite, anything, generalized, everything, negative, nobody, personal I, possessive mine, reflexive myself. So some excursus to linguistics for you. And at the stage of component lexis analysis, we evaluated keywords and then analyzed each text according to the number of semantic categories presented in the text, or extra items, archaic items. For example, we analyzed the utterance from the excerpt of patient with mild depression. I was useless and didn't help anybody, neither my daughter nor my grandchildren. According to a consensus-based opinion and component lexis analysis, we found keywords useless, help, daughter, grandchildren. Here we unite them into semantic ranks like help and aid and relatives, and the semantic team to help relatives, and the associated semantic category family. We relied on the semantic teams and categories classification presented in the investigation for Russian language speakers and validated for Russian language. Within such semantic categories like altruistic, within the teams to help others, to do good to others, to improve the world around one. Existential category, hedonic, self-realization, social status, communicative, family, cognitive, to know oneself, to know God, to understand life, and etc. And our results: mild stress-related depression was characterized by the following signs and symptoms. Depressed mood consisting of sadness, sorrow, irritability, despondency, and melancholy. Mood swings during the day with predominant hypothymia. More prominent mood change in reaction to current life event on daily basis. Distorted quality of life and perceived as a pattern of unwanted or even alien behavioral reactions. Dystonic. Partial anhedonia and distortion of self-image to reflect low self-esteem, lack of self-confidence or self-dislike, difficulties in decision-making, as well as pessimistic perception of current life events, a negative view of the past with emphasis on mistakes and failures, loss of energy, fatigue, and lack of interest in social activities, sleep disturbances, change in appetite, reduced libido, in anasthenia, lack of energy. Normal sadness, however, was characterized by adequate self-perception and perception of life events as an adequate and appropriate reaction to the event happened. A constant subjective feeling of dissatisfaction regarding objective life circumstances arising from external reason, but focus on present difficulties while analyzing their decision-making and problem-solving strategies and describing future aspirations as compared to patients with mild depression. Continue their usual daily activities, but with some muting of interest and periods of ruminations accompanied by feelings of sadness. And for psychometric measures, we use this Hamilton Depression Rating Scale 21 assessment. The groups differ significantly between each other. Mild depression, normal sadness, and euthymic state, you can see at the slide, and using ANOVA with significant pair between groups difference found using post-hoc Bonferroni correction, describe difference of the groups via HDRS assessment. Written language of patients with mild depression demonstrated distinct peculiarities, patterns. There are no significant or strong correlations were observed between linguistic variables and the factor of gender, not gender related. The average of inter-rate reliability on linguistic variables between two blind raters was quite high, so the data are reliable. Patients with mild depression produce longer written responses compared to healthy controls. The mean number of words per text was 311 for mild depression versus 209 for normal sadness and 197 for healthy control. Responses in patients with mild depressions compared to those in healthy controls were organized more often as narration and less often as reasoning. It could be also associated with this lack of decision-making strategies in patients with mild depression compared to people with a state of normal sadness. So these texts were more often written in a descriptive rather than analytic manner. Patients with mild depression used more colloquialism or informal words and phrases, which are not typical for written language. And here you can see the data and all the statistics related to phraseologism, informal words and phrases. Also, patients had more repetitions, both with respect to reusing the same words, tautologies, and to expressing the same idea multiple times in different ways, lexical and semantic repetitions. Patients also use significantly more metaphors and similes, figurative language. So figurative language was more often an abstract language, or more often presented in mild depression rather than in healthy controls and euthymia state. And in comparison to euthymic healthy controls, the normal sadness group was impoverished at the lexicosemantic sublevel, showing greater use of tautologies and repetitions in general. So people with normal sadness are also over-focused on their problem and repeat the topic in their texts. 99 patients with mild depression, so about 80% compared to only 2% of healthy individuals, predominantly use single clause sentences. Among single clause sentences, the reduced sentences appeared and often predominated in 73% of patients with mild depression, which also could be associated with asthenia and anergia, lack of energy in patients to produce longer clauses. Among multi-clause sentences, compound sentences were predominantly used over complex sentences by the majority of the patients with mild depression, because they often describe but don't try to find the reasons and don't try to make decisions. They are overwhelmed with the situation, with the problem, with the sadness about these problems, and they are drawn in this information, not trying to decide to solve it, which is related to using these compound sentences from our psycholinguistic point of view. A predominant atypical inverse word order usage was also revealed in patients with mild depression. Normal sadness participants used atypical word order forms such as ellipses and inversions, more often than participants in euthymic state, but less often than people with mild depression. Patients' responses contain significantly more personal and indefinite pronouns compared to the state of normal sadness and euthymia, and it replicates the data we showed you above. Data demonstrated greater usage specifically of first-person singular pronouns, such as I, me, my, and mild depression compared to healthy controls. What is very interesting, and it was the first finding in our study, that patients with mild depression predominantly use verbs in continuous tense. So they are doing something, but not completed. And in past tense, they are shifted into past events. I didn't succeed, I wasn't loved, I didn't love, they didn't love me, they didn't want me, and so on, mostly in first-person singular and in personal forms. While mild depression used more continuous verbs in the past tense significantly and with large effect size, really, as shown above, healthy controls used perfect tense verbs more often. So they've done, they completed, and verbs in the present and future tense. So they're focusing on the present and planning their future. And it's proved by language indicators, by the verbs they use in their speech, in their written speech, even in texts. Language in normal sadness compared to normal healthy controls included more verbs in continuous form and in present tense, because they are also focusing on their problems, which they are planning to, however, to solve, compared to patients with mild depression. And here you can see the numbers related to pronouns. Semantic categories, it was also very interesting finding. They describing existential and family values, which were exaggerated in the narratives of mild depression patients compared to healthy controls, while cognitive and altruistic categories were mentioned significantly less often. So family and life itself were more of value for people with mild depression rather than cognition or altruism or doing things with others, in line with the rest categories. However, such selected themes within the categories, such as to love from the existential category, to live for the sake of the family from the family category, and to know God from the cognitive category, did not show significant differences between mild depression, people with euthymia, and persons with normal sadness. So it means it's some basic we really follow in our life, like values, family, God, so some religious myths, and some force word, like to rely on the group of support, family, and some force, some belief, which helps us to survive and cope with the difficulties. And love, which is also the eternal value. It was the same for all the groups of people. And you can see the ranking, which we have been already described regarding the component lexis analysis of texts. What's about mathematic modeling? When we exclude semantic variables and only focused on lexical, grammatic, and stylistic indicators, we found absolutely clear differentiation of states of normal sadness and mild depression. However, you see that normal sadness was close to the group of euthymic state, but the mild depression is absolutely separate. So if we hear some words, they can be absolutely clear indicators for us that it is depression or it is not a depression. For example, pronouns or verbs in past tense. When we add semantic features, we also have the same in mathematics, almost the same in mathematic modeling. You can see that mild depression is separated from the state of normal sadness and euthymia. Moreover, normal sadness and euthymia within semantic issues separated even better as compared to lexical and grammar linguistic variables. In order to test the hypothesis if it could be associated with personality traits, we grouped our patients with mild depression with anxious features and mild depressions without anxious features. And so you can see in red mild depression without anxious features, and blue triangle normal sadness, and mild depression with anxious features, these stars. These group centroids were different. No matter mild depression with and without anxious features were very close to each other in the mathematical model, the group centroids are different, statistically significant different. It means that really affect the type of effect, for example, anxiety effect in the clinical structure of depression is related to language and is represented through patient speech. Not personality or other psychosocial factors. However, of course, we need further research to clarify these important issues. To conclude, mild depression is characterized by patterns of atypical language use both in structure and content of speech, distinguishing depression from normal sadness and euthymic state, which points to a potential role of linguistic indicators in diagnosing affective states. In mild depression, as compared to healthy individuals, written responses are longer. They demonstrate descriptive rather than analytic style. Signs of spoken speech, oral speech, and figurative language use. Single clause sentences dominated over multi-clause. A typical word order we can observe in the speech of patients with mild depression. Increased use of personal and indefinite pronouns such as I, mine, and verb use in continuous, doing, imperfective, and past tenses, did, also presented. This is one of the findings of our Russian sample, actually, which haven't been replicated in foreign language yet, and it could be an idea for research. If you are interested in, you can contact our group. In normal sadness as compared to healthy control, we found a greater use of lexical repetitions, omission of words, verbs in continuous and present tenses. So we can see here. So this is the fixation on present and on continuous, still uncompleted, still in the problem, still inside the problem. And it is reflected in the lexical items in linguistic variables, which we can hear with our eye, which we can hear in language clinician turning into linguists this way. The highest predictors in discrimination between mild depression, normal sadness, and euthymic states are the following variables: atypical word order, ellipsis, omission of words, colloquialism, informal words or phrases, verb tense, verb form, continuous or perfect, amount of reflexive, myself, pronouns, and negative, like nobody, in a definite pronounce. Evaluation of psychosocial themes should be also heard by clinicians. Such exaggerated topics about family and existential categories and how to live and what's happening with the family, and decline in values of self-realization about work, about career and social status, and achievements within the content of narrative should enable a better understanding of pathogenesis of mild depression from the psychosocial point of view or cognitive linguistic point of view, to emphasize the importance of monitoring social difficulties during treatment. And the social difficulties, they are very often are related to those psychotraumas and those social stresses our patients experience. So the key point message of my talk, it is equally important to pay attention and listen to what patient speaks about and to how it's spoken, using which words it has been spoken. And here we really can observe the targets for psychotherapy interventions, like it is used for in neurology and speech pathologists who deal with strokes and aphasias when they use this intensive language action therapy. So focusing on our finding, what is vulnerable in patients' speech with mild depression, we can teach our patient to speak normal language, healthy language, again, to train particular lexical patterns, semantic patterns, syntactic patterns, via different computerized and exercises and group and individual cognitive therapy sessions. Perspective of psycholinguistic research in psychiatry and psychotherapy of the stress-related and psychotrauma-related depressive state. First is to make diagnostic markers of depression as a mental health state, objective, while language as objective phenomena, behavioral phenomena. Second is the observation and evaluation of evidence-based treatment targets and apply it for the language remediation therapy within the complex of cognitive remediation, and the evaluation of the psychotherapy and psychosocial interventions efficacy measuring language in dynamic before and after the course of treatment. And we also work on different linguistic research related to schizophrenia in Australia with a group of Professors Jablensky and Joanna Bedkirk. For example, we studied verbs and we found that patients with schizophrenia, they have impaired action verb production but intact mental state verb generation. And they have difficulties with actions and motorics. So we can find many things, many clinical issues while studying language aspects. And also with a group of Israel, we studied language of migrants, Russian Hebrew migrants with schizophrenia, bilingual patients, and we found that second language provides a compensatory resource to maintain verbal fluency and preserve communication. So there is another way on pathogenesis of schizophrenia. There is internal motive and intention to preserve communication, but there is a failure on how to proceed with this communication in our patients. So again, through language, we can find new targets for psychosocial, psychotherapeutic, and combined intervention to treat our patient, to help our patients. The details you can also see in our chapter on schizophrenia and bilingualism, published in Canadian Handbook of the Neuroscience and Multilingualisms. I express my sincere gratitude for your attention, and I'm ready to answer your questions and join discussion with the audience. Thank you so much.